All right, this is Dr. Moses, and we are going to go over systemic lupus erythematosus here. So, what is systemic erythematosus? Or we also will call this SLE or lupus. All right, and this is something that can have debilitating effects from an autoimmune disease, but it can impact multiple different systems in the body. So we can see issues with our skin, and I'll kind of show you some pictures, but pulls up here like the butterfly rash, cardiovascular issues, pulmonary issues, musculoskeletal is a big thing that we see here, and our kidneys can also be damaged as well. We can have permanent organ damage if we do not treat it appropriately and can have serious consequences for our patients. So what's going on inside the body here is we have our B cells or T cells, abnormal functioning cells in our body that are used to fight off infection, but the autoreactive B cells produce antibodies that attack and destroy healthy tissues and organs, and they can cause widespread inflammation. So like this is just going to kind of zoom in on the kidneys, but this could happen anywhere. So what happens in our blood, our immune system attacks and damages like nephrons here in the kidney. So our autoantibodies bind to DNA to form these immune complexes, okay? And one method of tissue damage is when those immune complexes or those antibodies then deposit on like the podocytes here in the glomeruli. So this then is going to cause damage to the kidney, can cause inflammation, can then cause buildup of waste in the blood, protein to be excreted, we can have blood in our urine. So it doesn't matter really where this happens, but what's happening is there's either some genetic alterations, which I'll also pull up, thought to be, we don't know exactly what causes it, but we do believe that there's genetic alterations within our body that then will cause these B cells, T cells to start functioning in a way they shouldn't, where they produce these pro-inflammatory molecules which cause inflammation, and then they cause these autoantibodies that then will kind of latch on and attack our cells. Okay. We also think that the environmental exposures then kind of can make things worse. So etiology and genetic risk, we don't know exactly what causes lupus. It's thought to be related to genetic, immunity, endocrine plays a part into this, and environmental factors are thought to cause the body to develop an anti-self response. There is also a known strong hereditary component to SLE as well. So triggers are thought to be things such as hormones. Estrogen is a big one. And when we can make that connection that estrogen is a big, reason someone might have SLE, it helps to understand then who this most commonly impacts, which is women. Infections are thought to, bring this on. Medications such as estrogen-containing contraceptions, postmenopausal hormone replacement. So again, we're thinking those hormones. But another big thing that we see with SLE or lupus is UV rays and sun exposure is a really big risk factor for these folks. So we really have to make sure we teach them to avoid UV rays, lots of sun exposure, that kind of thing. Smoking is another environmental exposure that can cause flares with SLE, and then stress. So again, we're thinking they've already got this genetic issue, mutation with these cells. We've got this genetic susceptibility. So they might have like mild, or it might even be completely in remission, but then we add in some of these environmental exposures, and then that's when we start to get some of the flares. So we really try to eliminate as many of those exposures as we can to prevent them from going into flares. So our incidence and prevalence. So variable prevalence among ethnic groups, highest prevalence is considered like the American Indian, Alaskan Native females, which is 34%. African American females is 29%, and Hispanic females is 15.3%. But women in the reproductive years are the most at risk, and women show a 9-to-1 ratio compared to men when it comes to the development of SLE. So again, women are really your ones at greatest risk here. And then when we break that down even further, we have the highest prevalence in your American Indian, Alaskan, Native females. So some of the clinical features of SLE or lupus, and we'll go into it a little bit more with some pictures here in a second, but there are multiple areas of the body that can be impacted. The onset is usually slow, and the symptoms may be mild, general, and vague, so diagnosis is often difficult and delayed. Our exacerbations or flares then accelerate organ damage, so proper management is important to prevent long-lasting damage. Not all organs are impacted, and depending on the severity, might present with just some different clinical manifestations. So like, for example, if we had a flare, and like the video I showed earlier, and it impacted the kidneys the hardest, then you can see the hematuria and proteinuria due to the poor filtration ability of the kidneys. If our heart and lungs are more impacted than our kidneys, then we might see more like chest pain with breathing if we've got like pleuritis or something like that. So it just kind of depends on what part of the body is really most impacted that might help explain some of the features that you could see. So some visible manifestations of lupus here, I thought this was a great visual tool here, is usually related to like the musculoskeletal and integumentary involvement. So, and it's not pictured, but if you think about chronic systemic inflammation, another symptom that you might see with lupus would just be a chronic low-grade fever, just because your body's constantly in a state of just dealing with this inflammation. One of the first observable symptoms directly linked to lupus is the malar rash, or we also call that like the butterfly rash that develops on someone's face, especially after sun exposure. Okay, you can also have discoid rashes with lupus, but these can occur on like the face, scalp, sun-exposed areas, and these over time can like leave scarring. So I always say like that butterfly rash, that's kind of one of those key clinical manifestations of lupus that we use to help in some of that diagnosis of the disease. The musculoskeletal changes, such as arthritis, muscle aches, muscle inflammation, are common due to hypoxia caused by the vasculitis. And then also like with the joints, like if we have synovitis, which is that inflammation of the synovial joint and the synovial lining, then we start to get like that joint pain, that arthritic pain that comes with that. So typically with this, it's bilateral, it's not unilateral. We see it on both sides. And you think about your most common joints that would be impacted, of course, would be like your feet, ankles, knees, wrists, fingers, that kind of thing. All right. And then this kind of goes back, if there's cardiac involvement or anything like that, you might see some of the Raynaud's phenomenon. But like that vasculitis, again, we're thinking it's just the very small vessels can then lead to some of that visible presentation there. Things you can't see with lupus that makes it really hard to diagnose, and it's just very subjective in nature, but would be like just the generalized achiness that comes with it, having a chronic headache. Fatigue, chronic fatigue is very common, although they don't really know the cause of it. It's thought to be related to either like stress, depression, ongoing inflammation, and insomnia, which would be due to just constantly being in pain, or if I'm on like corticosteroids for some reason, that could also be causing some insomnia as well. So how do we diagnose lupus? And this is really difficult because there's not a set test that says you have lupus, right? If you look at table 17.2 in your book, it does kind of break down the lab work that we would look at. So we do know that we can have anemia and leukopenia in lupus. So we would be looking at our red blood cell count. So if it's low, that could be indicative. But again, we know if we've got anemia, a million things can cause anemia. So it's not like we can just use that as a definitive answer to our diagnosis. In the CBC, they can look at white count because, again, leukopenia may be seen with SLE. An increase in monocytes can indicate chronic inflammatory disorders, and an increase in eosinophils can be present in autoimmune disorders as well. With that CBC, we can also look at our kidney function. So we can look at our serum creatinine and see what's going on with that. And then I will say one big lab we do look at is the ANA profile, which ANA is anti-nuclear antibodies. And so ANA is present in over 95% of people with SLE, although it is present with other autoimmune disorders. And even some healthy individuals, up to 3 to 4% of people who are healthy, can also have positive ANA markers. So it's not specific just to lupus. So they use it in correlation to signs and symptoms that would be attributed to lupus. That being said, if you got a negative ANA profile, they're going to use that to rule out lupus, since over 95% of people who do have lupus do have positive ANA markers, if that makes sense. So another lab diagnostic we could look at would be UA. Again, this is just looking at kidney function and if there are red blood cells or protein present in the urine. And then, I did put on your other diagnostics are really there to help rule out other disorders. So for example, if they came in and they was having some cardiac, involvement, well, then they might have some chest pain. So then we're going to have to do an EKG to rule out there's any EKG changes that could be present. If there's kidney impairment that shows up on our lab work, well, we might have to do a renal ultrasound to make sure there's not just an acute kidney injury or obstruction or something like that that could be causing the kidney problems. Same thing if they came in with some neurological deficits, well, we would have to do CT scans and MRIs to rule out things such as stroke, dementia, TIA, that kind of thing. So the other diagnostics, again, don't tell us, yes, it is lupus, but they help us to rule out other disease processes that we could be looking at that could cause some of the symptoms as well. So what does treatment for lupus look like? We don't have a cure. This is just autoimmune. So the treatment really is to try to help with the symptoms and the systems affected, and to look at long-term medication regimens that we use, such as some people might be on long-term use of corticosteroids. They might stay on immunosuppressive agents, that kind of thing. So they might be on some medication regimen to kind of help prevent flare-ups and to help keep them in remission, because our whole goal is to eliminate those flare-ups that can then do organ damage and organ failure. So the main things, like when we think about with treatment, the arthritic pain, the joint pain, all that is a big piece of this that they deal with on a day in, day out basis. So of course we're telling them NSAIDs and acetaminophen, Tylenol. Now granted, we know Tylenol is not anti-inflammatory, but sometimes, just alternating between the two, the Tylenol will help with some pain. If they have a flare-up that has really got some of the arthritic pain really out of control, then they might use like a short-term taper of steroids to kind of help with that flare, to help with some of the pain as well. In some states, they can look at your medical cannabis. It just depends on where you are. And then, of course, when we think about like just joint pain, we're thinking proper rest, avoiding triggers and stress that can cause flare-ups, low impact activities for joint health. Just again, I had somebody teach me that, motion is lotion, and if we've got synovitis, and we've got, some tenderness and some achiness in that synovial joint, moving, kind of helps with some of that synovial fluid, which then can kind of help with some of that discomfort. And then we want to reduce sunlight exposure because, again, we know that is an environmental risk factor that puts them at risk for flare-ups. And then we know like moist heat, saunas, that kind of thing could be great for these individuals if they're dealing with some joint pain. Then we look at fatigue. So we want to manage our lifestyle, find ways to conserve energy. So plan rest periods, shop online when possible, plan meals ahead. It's okay to say no to activities if you know it's going to be very taxing. Let others help you around the house. Good sleep schedule, obviously. So just thinking about, decreasing the amount of caffeine you take in so you get better sleep. Ways to manage fatigue. And then preventing organ failure. So like I said, some of these people might be on steroids to begin with, like prednisone. They're a cornerstone of treatment. They're general inflammatory immunosuppressants that affect all cells. So they do come with several side effects, as you remember. Most considerable to think about. You've got sodium and water retention. Because of that, then you get high blood pressure. You hear people have the jitteriness that comes with steroids, so some of that anxiety. You can have insomnia, that kind of thing. And we can really see like that with if they had a flare and then maybe they were on a management, so a full-time, always on a maintenance dose of steroids, but then if they had a flare, they might increase that dose. But if they are on long-term prednisone use, then we can see the weight gain, the moon face, and buffalo hump, does have immunosuppressive properties, so then they are more at risk for colds and other infections. And also remember, of course, with steroids, we cannot abruptly stop these, so we need to make sure we teach them that they do have to be tapered off to take them as prescribed if it's used for a flare, that kind of thing. Our anti-malarial drugs, such as hydroxychloroquine, are known to assist patients to go into remission by having an anti-clotting effect that helps with the symptoms and issues related to the vasculitis, but it also works to decrease the absorption of UV light in the skin cells and then therefore decreases the risk of skin lesions. That being said, with your anti-malarials, with your hydroxychloroquine, the major complication is toxicity to the retinal cells, which can lead to irreversible loss of central vision. So it is very important that these individuals, if they are taking this medication, get frequent eye exams to check their peripheral vision and do their vision fields to make sure they're not losing their eyesight. Immunosuppressives. So cyclophosphamide, azathioprine, methotrexate would be examples. They're used to keep the body from attacking itself. So we know, though, with immunosuppressive agents, if they're taking those, it is suppressing their immune system. So they are at a greater risk of infection. So they need to avoid contact with ill people, have good hand hygiene, and then if they do have any fevers, they need to be reporting those to their providers. And then finally, we have monoclonal antibodies that have been used successfully to help control autoimmune disorders. And these can be given IV or subcutaneously. One that I want to point out, your book talks about it, it is an approved treatment for SLE, is belimumab, which is Belimumab, and it works to reduce the autoantibody levels in the body. So if they do receive that, though, it is given in an acute setting, either IV or sub-Q, and so it cannot be something they take at home. And then they do have to monitor them for up to 2 hours post-infusion to make sure they don't have any hypersensitivity reactions to the medications.